My name's Richard Hughes. I'm from Meridian Bioscience, and I'm just going to showcase one part of our range, but the common platform is illustrated or shown by this picture up on the title slide here, which is our Illumigene platform. So it's a lamp platform. It's isothermal in the way it works, and it first entered into the commercial arena 2010 with a 510K FDA approval for C. difficile, actually, which fits in line with what the previous speaker was talking about in this theatre. So today is about malaria, Illumigene Malaria, and this is, as a company, this is our first vector-borne or blood-borne pathogen. So this is for the detection of all Plasmodium species, so from Falciparum through to Knowlex, but it does not speciate, but I'll hopefully impart some value as to why it's useful and why it would be considered very useful in the marketplace. That's across Western Europe and also in the highly endemic regions, such as Sub-Saharan Africa. Okay, you'll just see that we've picked up an award earlier this year. That was in June at the Journée Internationale de Biologistes and CNBH meeting in Paris, and that was in the category for innovation for emergency treatment and point-of-care testing. So it's starting to collect some attention and accolade. We've heard a lot of statistics this morning, especially from the plenary lectures that went on. Philip Howard spoke about the frightening figure attached with death rates and the stats that have been passed around about antimicrobial resistance. This one has some equal gravity attached to it, that there is still one child whose life is claimed every 2 minutes. So if that's still happening, then in our view, it's time to change the way we test as well as prevent and treat. So just to point out that the perception and sometimes some of the historical rhetoric has been, well, that's Sub-Saharan Africa. The endemicity, the bulk of the burden rests in Africa or perhaps even in India. Well, we all travel. I guess many of us travel a lot more, and many of us are traveling to some quite exotic places. I was speaking to Kate earlier from Knowlex, the organizers, who'll be going on a tour in the Far East, Thailand and Cambodia. That in itself has some malaria problems, shall we say. So I think with that in mind, those returning to countries where their families have been brought up, or returning to high endemic or regions of high endemicity, or those simply traveling out there for the first time. I'm about to go to Senegal at the end of this month, on the 25th. So I've had all my shots, and I've got Malarone in waiting. So I need to start taking that about a day or 2 days beforehand. But looking forward to that trip, because that's for a pre-elimination program of which this will be part of. So the worldwide risks are all there to be seen on the WHO website, so I don't really need to reiterate any of those. But the burden still in 2015 came out at around 438,000 deaths. So it's something we can do something about. And the insecticide-treated nets, the long-lasting ones, the treatments, the prevention, the education programs are all part of this, as well as the diagnostics. There's symptoms, they're febrile or fever symptoms with all of the species. Falcip and Vivax get most of the attention with volume associated with those, clinically speaking. But the point is, if you can make a definitive diagnosis, and that's what we're trying to achieve with this, take out some of the uncertainty that's experienced if we're in a laboratory that are not running into too many positives, or perhaps have a degree of uncertainty in actually calling a negative as well with some of the traditional methods, such as microscopy, because we're seeing a diminished level of expertise there with microscopy, not enough skilled pairs of hands and operators behind that, or the use of RDTs, which quite frankly can't cope in submicroscopic low parasitemia levels where they're trying to achieve elimination. Okay, so just a quick mention of the treatment for malaria and some guidelines there. I've mentioned some of the current techniques that are available. PCR, of course, is available, and there was a LAMP method coming through from ICAN, which was popularized by the Foundation for Innovative New Diagnostics. Now, that LAMP method is a lot longer in terms of the workflow, the laboratory workflow, which is why we think we have something quite different and quite disruptive here with Illumigene. So that's the procedure card for the quick method. The hands-on time is 2 minutes. This is a molecular platform. I'll just reiterate that. So it all happens at isothermally. There's no additional heat step, and the time on the instrument, on the incubator and the reader is 40 minutes. So in 42 minutes, you will get a definitive diagnosis. It works on LAMP, so the byproduct of LAMP is magnesium pyrophosphate. If it's turbid in the tube, that's indicative of positivity. So that's a qualitative test. This is currently CE-IVD marked for Europe. My definition for Europe encompasses the territory we cover, which is anywhere from the Atlantic to the Himalayas, I'm afraid. So there's a lot of air miles generated. However, we are looking to power up the clinical trial, which is in collaboration between the CDC in Atlanta and Professor Dowda, the principal investigator in Dakar, Senegal, which will go through for a 510K and FDA on this. So you can see just from the captions on the left here about the sensitivity of the system. I just came back from the Netherlands last week, and there's a multi-centered international study being led by Tom van Gool there. And basically, he's so far, the early data, of which is about 163 samples prospective, 43 of which are positive, the rest are negative, and they're lining up or comparing this Illumigene versus an RDT, I think it's a Binax RDT, and microscopy as well. The RDT has produced 1 false positive and has missed 3 ovales so far. Illumigene has scored 100% total concordance with some very high-level expert microscope readings. So these are really finely tuned microscopists. So far so good on that study, and he's looking to publish that and perhaps have an oral presentation in Vienna ECCMID next year, but certainly we'll look to get it into JCM. There should be a Nature publication that we're looking to get out. The manuscript's under referee review and question at the moment, and that's being led by Professor Dowda and 2 of the malaria people out of Atlanta. So that's John Barnwell and Naomi Lucci. So more to follow on that system. This procedure card on the right is a slightly longer procedure. I say slightly longer. Read into that 5 minutes versus 2 minutes of hands-on time, but you've still got 40 minutes on the machine. So that's 45 minutes versus the previous version, slightly quicker. So essentially, you get a slightly more, or actually there is more sensitivity there, and this, a blend of this system and the simpler version, so this more sensitive version, excuse me, get the words out, is called Illumigene Malaria Plus. Our entry-level version is called Illumigene Malaria, but they'll probably be using a blend of both of these in the northern regions of Senegal to achieve pre-elimination status, which is what they're gunning for by 2018. performances there, just a visual on that. And there's some posters coming out of the American Society of Trop Medicine and Hygiene. We'll be having a presence there again later this year at that meeting. And there will be Professor Dauda and Carlos Severini from the ISS in Italy speaking about picking up 2 subspecies of Avali, actually, with the use of this system. So that's the AMP poster. If anyone's interested, I'll be around at least until 5. I've got to drive back to London, so no wine and reception for me, I'm afraid. But catch me, I can give you a business card later if anyone wants to talk about this further. There are some videos which sit on our website, so I would just urge you to go on and take a look at those. They don't last very long. It's pretty quick, and that's on Meridian Bioscience.eu. Here's the rest of the menu. As I say, we started with HAI, gastrointestinal. That was back in 2010. We went through with neonatal and women's health, GBS. We've got a respiratory portfolio, an STD portfolio, and following malaria, there's babesia in the pipeline, and surely more to come as well. The key with this, why would you consider this rather than a Cepheid gene expert or another system, let's say? It's about 11 by 8 inches, the platform. We don't really sell it as an instrument because there's no service contract. We place them in there. Commercially, it's sold, or the revenue's taken through the tests that are run on it. And quite simply, there's no bulky equipment, and all of the reagents for malaria can sit quite happily under ambient conditions as well. We've tested that because they've been in hot regions out in Africa. Okay, some of you may have seen in the guide already, there's an ad of that award and some verbiage that associates that. Here's a picture of Professor Dauda Enjoy from Dakar. So he's the lead researcher at Sheikh Anta Diop in Dakar. So that's where we'll be heading out to, some colleagues, the team and I, later on this month to start talking with the NMCP, the National Malaria Control Program team, about implementing, or the first stages of implementing, that pre-elimination program. So just a soundbite from Tom van Gool, the Dutch PI who's leading the Western European lab study. His verbiage to me was along the lines of, okay, we now have a highly accurate and easy way of excluding malaria infection, particularly during out of hours or night shifts, where you've still got that level of uncertainty or you don't have that skilled resource available at those times. And that's in Western Europe. When you're thinking about a burden in a country such as Senegal, with such high endemic, or a mixture, sort of a heat map, if you will, of high endemic regions mixed with low asymptomatic carriage, then there's a different type of challenge going on in both regions. Okay, just more verbiage about the award there. And this lady, Meredith Kozak, is not actually a scientist. She's a cultural and linguist consultant that we employed to help us locally. There's Wolof, which is the local dialect and language in Senegal, and there's also French. I'm lucky I speak French fluently myself, but I know no Wolof whatsoever. So Meredith was there to help us. She's a non-scientist. She's actually studying at the London School of Economics. And basically, we took her into Cincinnati, which is where our headquarters are, trained her for 1 week, and she went back out into the rural areas and trained the local technicians. And they are now running that as part of the clinical study there. So she had some pretty good things to say about the system. We've also, so Illumigene is already in the UK. I think we have something like 15 systems dotted around. the UK, largely for C. diff. There's some CTNG, HSV. Malaria has recently gone into nobles at the Isle of Man, and we also have one in the hematology group at Adam Brooks Hospital with Gareth Davis as well. So again, what people are saying to us is, in coming from microscopy and RDTs or using other molecular methods, they find this as a very nice, accessible, affordable, and highly accurate alternative. Okay, so there's our website again, just for any of you that are interested in this or any other products. That's a famous face there. He got his Olympic gold medal as well. I'm sure some of you may know that Andy Murray and David Beckham, in fact, are the two leading faces behind Malaria No More. So part of our quest as a company is to reach out to some of the NGO groups, the likes of Bill and Melinda Gates Foundation. I'm also trying to talk with DFID, which is the Department for International Development, because they have the Ross Fund and various other means and mechanisms of trying to spread, let's say, good practice and best practice, as Barbara had mentioned in her talk earlier. Why wait for a level of evidence that may take years to accrue when there could be sufficient evidence there for an intervention to make an impact to someone's lives or population lives right now? So with that, I'd like to close. Thank you.